The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day everyone. So welcome to the Hema Onco part of your review in internal medicine. So now let's go to hematology. So what makes hematology a little bit different from your other subspecialties is that hematology requires a lot of understanding before you'd be able to answer the question. So it needs comprehension of the laboratory test. You need to analyze the clinical presentation and the laboratory findings before we go to the question and answer portion. It's not like your other subspecialties wherein it's a little bit more black and white. So you'd notice that for the hema part of our discussion, medyo mas magdadwell tayo dun sa pag-understand ng approach to anemia, understanding the laboratory values, and even a little bit of computations. Okay, so without further ado, let's go to the meat of the matter. So what's anemia? Anemia is a decrease in the red cell mass, and the WHO will define this as a value less than 13 hemoglobin among men and a value of less than 12 among women. So in Harrison's, actually, there is no mention of a hematocrit counterpart for the definition of anemia. But a little tip, if you're going to estimate the hematocrit based from the hemoglobin, so in medical technology, we actually have the so-called rule of threes. So pag times 3 mo sila, example, 13 in men, so pag times 3 natin, that's around 39. So that's roughly the value of the hematocrit. Okay, so at least in a way you can estimate. So of course, pagdating sa anemia, everything naman dapat may thorough history and PE. But other than that, what's important here is that you need to check the red cell indices and the peripheral blood smear. Okay? And other than this, you need the reticulocyte count to check for reticulocyte response. So pag tinanong tayo, what would be the most basic laboratory test that you would request for initially? There's a good algorithm here in Harrison's. Yung pinaka-top doon nakalagay CBC. And you have the reticulocyte count as well, other than the PBS. Okay? Because you need to check for marrow response. So when we're trying to compute for the red cell indices, you need to be familiar with these terms, MCV, MCH, MCHC. Okay, so these are your red cell indices, and then they can help you understand kung anong klase yung anemia ng patient. So MCV is a surrogate marker for the cell size. Okay, routinely, we do not measure for the direct size of the cell, but we estimate it based on the mean cell volume. So usually, ang red cell natin is around 6 to 8 micra depending on the reference. So kapag mataas yung volume niya, in a way, it tells us that the cell is big. Okay? So if the MCV is greater than around 100, usually sabihin natin na macrocytic siya. If it's below than 80, so usually we say that they are microcytic. Okay? And how do we compute for this? So it's simply hematocrit over the red cell count, multiply it by 10. For MCH and MCHC, they reflect now the hemoglobin content, So yung kulay ng cell natin, diba? Normally, your red cell would have a central pallor, diba? And that occupies 1/3 of your red cell. But if you have more hemoglobin concentrated there, you will have a decrease in that central pallor. So mas mukhang magiging dark yung red cell natin throughout the cell. Okay, mawawala yung central pallor natin. Okay, and that is reflected with your MCHC. And between these two values, it's actually the MCHC which is more important. Clinically, ito yung mas ginagamit natin, okay? To reflect the hemoglobin concentration. Yung MCH, medyo ini-ignore lang natin yan. Okay? The red cell distribution width is the degree of the anisocytosis. So for example, if you have anemia wherein the red cells, some of them are microcytic, some of them are normal, some of them are big, that would be reflected in your RDW. Okay, because anisocytosis reflects the variability of the red cell, and the RDW now will be a reflection of the degree of anisocytosis. Alright? So typically in iron deficiency anemia, you would expect an elevated RDW. So the reticulocyte count is very important in the approach to anemia. Okay, yung mga retic natin, these are the young red cells. Typically, they are released by the marrow and they stay or they remain as reticulocyte in the peripheral blood for a day or so, and then they become your mature red cells. So the normal value is around 1 to 2%. But of course, if you have an insult, for example, nagdugo ang patient, you expect your reticulocyte count to go up if the marrow is adequately responding. Okay? Of course, you want your marrow to produce more new red cells in response to the bleeding episode. And hence, your reticulocyte count approximates the bone marrow's response to anemia. But we don't really look at reticulocytes based on the percentages lang at face value. Pag example, nakita natin, 6% reticulocyte count, does that mean the marrow is adequately responding? So the answer is not necessarily. And that is the reason why we do a two-step correction. So the first correction, we want to correct the reticulocyte count because the percent may be increased, but the absolute number may remain unchanged. Okay, so we want to correct this because you want to adjust the reticulocyte count based on the reduced number of circulating RBCs. Okay? So, typically, kapag anemic ang patient natin, tas mas madami yung red cells, so ang isipin natin, ang taas ng percent retic. But when you get the absolute count, it's actually the same as a normal individual's reticulocyte count. So, how do we compute for the absolute retic count? So, that's simply the percent retic, multiply it by the proportion of the normal hematocrit, the patient's hematocrit over the normal hematocrit. So typically, this is something that you can also compute using the hemoglobin as well. So patient's hemoglobin over the normal hemoglobin. So get your cell phones nga, try natin mag-compute. Okay, or your calculators if you have them with you. So you need to be able to practice doing this para pagdating sa board exam, hindi tayo magpapanik kung paano tayo magko-compute just in case it pops out. Okay, actually this is something that you can also do manually. So for example, yung percent retic natin, sinabi sa question is around 6%. That's quite a good number, di ba? Sabi, medyo mataas yun, di ba? Kasi alam natin 1 to 2% yung normal. But your patient is anemic, no? The hematocrit is only 22. So times 22 yan. 6 times 22 divided by the normal hematocrit, which is around 45. So you have a value now of 2.9. So that's your absolute reticulocyte count. Okay? But later on, pag-uusapan pa natin further how we can do another correction. Okay? So ito yung correction number 2. So this produces the final reticulocyte production index. So this would account for the reticulocytes being released prematurely from the marrow, which has a longer lifespan. So when you get the reticulocyte production index, you simply divide the absolute reticulocyte count with the maturation factor. So for example, yung kaninang sinabi nating 6, no? 6% multiply it to the patient's hematocrit over the normal hematocrit of 2 point something kanina, di ba? You divide it by the maturation factor of 2, for example. So that gives you a value of 1.5. So now you know na kulang pala yun. Akala mo mataas yung 6%, but the RPI is only 1.4. So that's actually a reflection na kulang din yung bone marrow response. Okay? So here we have another example. Let's compute together. Nandiyan na yung sagot. Okay, you have a 24-year-old female with a 9% reticulocyte count. It seems to be quite high. Okay, so try natin ulit. Practice ulit. So the hematocrit is 23. So that's simply 9, multiply it by 23. So 9 times 23 divided by 45. So that gives you a value of 4.6. Divided by 2. So that gives you a value of 2.3. Okay? So later, tignan natin kung ano ba yung magandang RPI for patients who are bleeding, ano ba yung low RPI. Okay? So in general, that's the basic concept. No, you just need to get the maturation factor. Usually we peg it at 2. So here we have this picture on your right hand side that tells you yung maturation factor pwedeng 1, 1.52 or 2.5. But if you want to estimate it, usually nilalagay na lang natin siya at 2. Alright? So ito yung algorithm na sinasabi natin sa Harrison's, no? It's a very good algorithm showing yung mga differentials natin, okay? But again, the basics, basic laboratory test that you need to request for would be your CBC and then your reticulocyte count. And now we can compute for your RPI. So, pag sinabi nating mataas yung RPI, generally, this is a value of more than or equal to 2.5. So, this is a reflection that the marrow is responding. So, dinudugo, nawawala ng red cell, the marrow is able to compensate for that by producing more red cells. Okay? And that's why you would notice here, dito sa side na to, that for an RPI of more than 2.5, no, you would notice na puro hemolytic or hemorrhage yung mga differentials natin. Either blood loss, intravascular hemolysis, or conditions that predispose the red cells to be destroyed. Example, metabolic defects like G6PD, for example. Membrane abnormalities that promote cell lysis like hereditary spherocytosis, hemoglobinopathies, immune destruction, fragmentation hemolysis. So in short, puro destruction of the red cells. Punta tayo sa kabilang side. If the RPI is less than 2.5, no, ibig sabihin the marrow is not producing enough red cells. Meaning to say the anemia is because of something that's going on in the marrow. It's because there is probably something lacking, probably a nutrient that's lacking that inhibits normal production of red cells. So, tignan natin based on the red cell morphology. If normo-normo, typically these are hypoproliferative anemias. So, baka naman pala may problema sa marrow. Baka fibrotic na yung marrow. Baka may aplastic anemia, may aplasia pala. Or baka kulang sa iron. Or decrease in stimulation such as in cases of inflammation, metabolic defect, or renal disease. Sa kabila naman, no, if there is a change in terms of the size of the cell, so merong disorder in terms of maturation, di ba? Kasi kanina normal yung itsura ng red cell eh. It's really just a matter of producing enough. Okay? Pero ngayon, there is an abnormality in terms of the production. So baka may kulang. Baka may folate deficiency, B12 deficiency. Maybe there are drugs that inhibit or disrupt the normal production of red cells. Okay? Dito sa taas, you have the cytoplasmic defects. Examples would be thalassemia and sideroblastic anemia. Okay? So, yun yung mga examples natin under micro or macrocytic anemia with a low RPI. So, there you go. So, here, no, we have some mnemonics to help you remember some of the differentials. Kapag microcytic anemia, tandaan nyo na lang, tails. Dati palatandaan ko dyan, atis, pero kulang ng lead poisoning, no? So, tails, you have thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. Okay? So, kapag yung question natin ang pinag-uusapan, microcytic, small red cells, low MCV, right off the bat, you already have a set of differentials. You would be able to eliminate some of the choices natin agad. Okay? Worth mentioning lang na si anemia of chronic disease could be microcytic, can be normocytic as well. Okay? So, don't be surprised if may mga references tayo na nasa normocytic side siya. So, for hypoproliferative anemia, which would typically have a normal morphology, so, andyan naman yung mga examples natin. Okay? So, anemia, no, can be classified based on the defect, no? Marrow production defect, which is hypoproliferative, na-mention na natin kanina. So, these are just some of the tests that you can use, no? So, actually, majority of the cases of anemia would be hypoproliferative in nature. So, more than 75% of cases. Okay? So, if you're thinking of iron deficiency, we can request for iron studies like serum ferritin, iron, and TIBC. Okay. So, red cell maturation defects, basically, there's ineffective erythropoiesis. You can check for the deficiency of certain vitamins that we mentioned earlier, like folic acid, B12 deficiency, typically producing a macrocytic type of anemia. So, decreased red cell survival naman, no? This is very classic. So, tatandaan natin to, no? You want to check for evidence of hemolysis. And how do you do that? You check for laboratory values that reflect red cell lysis such as LDH, no? Ang LDH kasi, guys, is typically intracellular, nasa loob ng red cell. So, kapag lumabas yan sa red cell, tataas talaga yung LDH. Bilirubins, no? In particular, would it be the B1 or the B2 ang tataas kapag red cell hemolysis? So, of course, it's your unconjugated bilirubin, right? So, it's the B1 that would go up kapag hemolytic anemia. Haptoglobin naman, pag na-release si hemoglobin from the red cell lysis, magbabind yan sa haptoglobin. Therefore, the haptoglobin will go down. Okay? Urine bilirubin and urobilinogen. So, for your Coombs test, this is in particular when we're thinking of immune-mediated cause for hemolysis, mga autoimmune hemolytic anemias, pwede maging positive yung Coombs test, aka the DAT, no? Direct antiglobulin test. You can also check for cold agglutinin titers. Other specific types of hemolysis may need specialized tests. So, how do we distinguish iron deficiency anemia from thalassemia? So, actually, itong dalawang to, marami nagkakaroon ng confusion dito, no? So, both of them would have a microcytic hypochromic picture on your RBC, on your CBC and on your PBS, but there are some key differences, no? So, in iron deficiency, typically, you will have an elevated RDW, and you have an Menser index of more than 13. So, paano ba kinocompute yun? That's simply MCV over the RBC count. So, this is actually quite an obsolete test already, yung Menser Index, but you can also compute for it. At least it gives you an idea. But, of course, it's not 100% na ma-differentiate yung thalassemia from iron deficiency anemia. Of course, ano ba ang mababa sa iron deficiency anemia? Nasa pangalan na yung iron. So, invariably, your serum ferritin will be low. Whereas for thalassemia, this is typically normal to even increased. Okay? So, ang take-home message lang natin dito is, not all patients with anemia, typically a microcytic hypochromic anemia, will require iron supplementation. Okay? So, ang dami kasi natin nakikita, na kapag yung mga doctors natin, na kapag di na nila alam yung gagawin, magbibigay na lang ng iron supplementation. But, example, kung thalassemia pala siya, elevated pa yung serum ferritin. So, you really will not need further iron supplementation. Okay? So, again, let's quickly review sa hemolytic anemia. Ano nga ulit yung features, no? So, clinically, you can have jaundice because of the elevation in bilirubin. You can have pallor, as with any form of anemia. Elevated bili, typically yung B1 or the unconjugated type of bilirubin, and you will have elevated LDH. Okay, so reticulocyte count is typically elevated because the marrow should be able to compensate for the blood loss, okay, for the decreasing red cell count. So dapat nagtatry siya mag-compensate. So tataas yung retic count, mataas ang RPI, more than 2.5, and you will have reduced to absent haptoglobin. So let's go to the specific types, no? So let's just go through some of the more common types na baka lumabas, no? So hereditary spherocytosis is one of them. It typically presents with jaundice, enlarged spleen, and even presence of gallstones. So when you have a young patient with anemia, presenting with right upper quadrant pain, tapos enlarged spleen, you also want to suspect for hereditary spherocytosis. So, how do we actually diagnose hereditary spherocytosis? So, traditionally, we have the so-called osmotic fragility test. So, here, you basically get a blood sample from the patient and you will put it in different tonicities. Okay, so basically, red cells of patients with hereditary spherocytosis are abnormally susceptible to lysis in a hypotonic media. Okay? Bakit? Because they are less distensible, no? So, in the laboratory, you will see that the MCHC is typically elevated and then the RDW is also high, but the MCV is normal to a little low pa, no? So, pag sinabi natin MCHC of more than 34, it doesn't really mean to say that the red cell contains more hemoglobin. Okay? Because there is only a so-called number or amount of hemoglobin that can be contained in a red cell. Cannot exceed that limit. Okay? What happens here is the red cells would have an abnormally concentrated amount of hemoglobin relative to its size. Okay? So there's no causal treatment, but patients can get splenectomy depending on the age. No? May mga ganong factors tayo and yung severity as well. So this is a peripheral blood smear showing a patient with hereditary spherocytosis. So can you appreciate that some of the red cells do not have the typical central pallor? Nakikita ba? So for example, ito, itong binibilugan natin dito. This would have a nice central pallor, medyo mukha siyang normal naman, medyo maliit ng konti, no? Pero tignan mo yung iba, like this one, wala na siyang central pallor. This one, very, very faint yung central pallor. Okay, meaning to say, very, very concentrated kasi yung cell natin in terms of the hemoglobin content. Okay? So, G6PD naman tayo, no? So, this would confer a relative resistance against Plasmodium falciparum infection. And the problem with patients with G6PD is the acute episodes of hemolytic anemia. And they are typically triggered by certain factors. So, among the recognized one would be number 1, fava beans. Although in the Philippines, hindi naman masyado to, no? Infection and drugs. Okay, so in Harrison's, there's actually a good table there showing the different drugs that can trigger G6PD. And it's actually stratified based on the risk, no? Kung iba definite, iba parang unlikely to cause hemolysis in G6PD. So, sino ba yung mga drugs na may definite na risk? So, I want you to familiarize yourselves, no? So, example, Primaquine, Dapsone, your cotrimoxazole, nitrofurantoin, respiricase, and naphthalene. So, I know that we are always taught in parasitology that the anti-malarial drugs would trigger G6PD hemolysis. But in the Hema chapter, we learned that not all of them would actually have a definite risk. Okay? Yung iba, merong risk. Pero ang definite risk lang na sinasabi doon is Primaquine. The others, hindi. No? Nasa ibang category ng risks sila. So, in G6PD, you can typically see bite cells. No? Yung nakikita natin dito. Yan. So if you hear those keywords, ding ding ding, mga buzzwords natin, no? By cells, you have the presence of the Heinz bodies, which are denaturated hemoglobin. So you think of G6PD, okay, among your differentials. Next, let's go to paroxysmal cold hemoglobinuria. So CPCH, this would occur mostly in children triggered by certain infections, and you can present with hemoglobinuria. So parang tea-colored urine, no? And yung buzzword natin dito would be the so-called Donat-Landsteiner antibody, which has an anti-P specificity. So don't be confused between PCH, PNH, and CAD, no? Kasi puro mga may common terms sila. So si paroxysmal cold hemoglobinuria would have the anti-P Donat-Landsteiner antibody, which is characterized as a biphasic antibody. So why do we call it biphasic? Because it tends to bind to red cells at low temperature pag malamig. But the cell lysis happens at a higher temperature, 37 degrees. And typically, recovery would be the rule. So now let's go to PNH, or paroxysmal nocturnal hemoglobinuria. So this is an acquired chronic hemolytic anemia. More specifically, it's an acquired intracorpuscular na chronic hemolytic anemia. So there's actually a good table there in Harrison's that would differentiate which ones are acquired, which ones are inherited, which ones are intracorpuscular and extracorpuscular. Mahirap i-memorize, diba? But the key there, no, is that for the acquired intracorpuscular, meaning to say that the problem is within the red cell itself, it's only PNH that's there. Okay? So kapag sa exam may nakita tayo na acquired, tapos lalo-lalo na pag na-mention pa na intracorpuscular, that should ring a bell, PNH siya lang yun nandun. Okay? So you would have hemolysis, pancytopenia, and uniquely, there is a tendency for venous thrombosis. Okay? So ito yung unique sa kanya kasi usually we know na kapag hemolytic anemia, nagdudugo. Pero ito hindi. There's actually a tendency for venous thrombosis, and in fact, it's the most common cause of death among patients with PNH. Okay? So usually ang kwento nito, one day a patient typically feels well, one day wakes up one morning, complains of passing blood instead of urine. Okay? Or pwede mag-complain ng tea-colored urine in the morning. The gold standard is flow cytometry. You want to check for the absence of the CD59 and CD55. Okay? So those CD markers in the normal cells. So other tests, these are already obsolete. Yung sucrose hemolysis, acidified serum, or the HAMS test. So yun yung mga tests dati, no? Only of historical interest nowadays. Treatment. So in terms of treatment, we've made progress in PNH. We now have an antibody targeting the C5 component of the complement pathway. So you have the so-called eculizumab, and yung bago ngayon is the ravulizumab. So if you're using an older edition of Harrison's, wala pa yung ravulizumab dati, no? So bago lang din siya. Folic acid supplementation can be given, and nice to know na sa PNH, because you're losing red cells, no, iniihit natin sila, no, yung iron, no. So tawag dito, you can also benefit from iron supplementation because you can also develop secondary iron deficiency. So now erythrocytosis is an increase in hemoglobin above normal. So we have this table over here. Typically among males, it's a value above 17. And in women, it's a value above 15. Pero just a little bit of wordplay lang, no? So very specific kasi tayo in your books. They would mention that what value would be invariably associated with an increase in red cell mass. So it's a different cutoff value. Hematocrit yung tinitignan, more than 60 and more than 55 among women. Okay? So lower than that, more than 50 and more than 45 may be abnormal. Pero kapag invariably associated na with an increase in red cell mass, yung babang values na tinitignan natin. So memorize more than 60 and more than 55. So what is spurious erythrocytosis? Meaning to say, it's only related to the volume. It's relative to the volume. So example, pag dehydrated tayo, mas mababa yung volume. So it appears as if the red cell mass increased, pero hindi. It's only relative to the decrease in the plasma volume. Pag primary, we're talking about conditions that are clonal in nature. So neoplastic, example, polycythemia vera, and the other myeloproliferative diseases. Secondary, it should be secondary to something else, no? It's triggered by something. So kapag triggered by something siya, the mediator there is an increase in the erythropoietin. So example, yung mga nakatira sa high altitude environments, yung mga may COPD, hypoxia, no? So you want to produce you need more red cells, so the body produces more EPO as well. Okay? Whereas in contrast, kapag neoplastic siya, it's not mediated by EPO. So typically, the EPO levels are low or normal. Okay? So important points in history. So, check lang natin kung may secondary cause for the erythrocytosis, such as smoking, hypoxia, living in high altitude. Physical examination, look for some clues that would point more towards a clonal cause. No? So, examples, polycythemia vera, you would see splenomegaly, okay, and then laboratory testing. So there is a good algorithm in Harrison's, no, tackling the approach to erythrocytosis, no. So first off, how do we even suspect that there is erythrocytosis? There should be an increase in the hematocrit or the hemoglobin, right? And the ideal thing to do is to measure the red cell mass, but of course, this is not widely available. So oftentimes, there is an arrow going straight to this part right here, measure the EPO levels. Okay? Pero sa atin sa Pilipinas, di rin naman ganun ka-widely available ang EPO, no? So, EPO, no, if it's low, it points towards something that's clonal, meaning the body is producing more red cells than it's supposed to without the proper signals, without an increase in the erythropoietin, right? So, this is typically seen in myeloproliferative conditions, and that is exemplified by your polycythemia vera. Okay, so how do you confirm polycythemia vera? You get a JAK2 mutation testing. This is also available in the Philippines in some labs, so that would clinch your diagnosis. Okay, but of course, have to bear in mind that JAK2 is not specific for polycythemia vera. The other myeloproliferative conditions would also have JAK2 positivity with different percentages. Okay? So if you have an elevated EPO, dito ka na maghahanap ng secondary cause, no? Is it because of hypoxia, smoking lang ba to? Is it because there is a tumor producing EPO? So yun na, i-guide tayo ng algorithm. So measure O2 sat. If the O2 sat is low, no? So ibig sabihin hypoxic siya. So ano kaya yung nagko-cause ng hypoxia niya? Is it a lung problem? Is it a high altitude environment, no? And so on. If normal, check if the patient is a smoker. Kasi if a smoker yung patient natin, you measure carboxyhemoglobin. Baka smoker's polycythemia lang. If the patient is not a smoker, measure the O2 affinity. Baka mga hemoglobinopathies. No? So this is a little bit more difficult to diagnose. If normal pa din, medyo wastebasket, you look for a tumor source. Okay? In some patients with known malignancies, common to sa mga may renal carcinoma, may hepatoma, uterine leiomyomas, no? But the more classic one would be a renal cell carcinoma. So they would produce erythropoietin, and that would be the cause or the trigger for the increase in the hemoglobin values. So thrombocytopenia naman, no? So you have different mechanisms, increased platelet destruction. The most common cause would be the intake of drugs. Alright? So you have a decreased marrow production and increase in sequestration. Of course, you need to remember that the spleen would normally sequester 1/3 of the total amount of platelets in the body. So, eto na naman tayo sa algorithm. So, if you have a platelet count of less than 150,000, what's the first thing that you should do? So, you need to check, is this an isolated phenomenon? Is this something that's concerning the platelets alone? Or does it involve all of the cell lines? Does it involve the red cells and the WBCs as well? If it is abnormal, no, yung hemoglobin and WBC count natin. So, it's telling us that the problem is not just a platelet problem. You look at the marrow. Okay? That's why if it's abnormal, you go ahead and proceed to get a bone marrow examination. So, a BMA. If it's normal, check muna natin. Talaga bang mababa yung platelet count? O baka naman it's something that concerns the manner to which we extracted the blood. Okay? So, baka naman sa peripheral blood smear, it shows us that the platelets are already clumped, no? So, you want to redraw in a sodium citrate or a heparin top. Okay? So, yung blue na top or a green top with the heparin. Okay? So, we have the so-called platelet satellitism kasi, di ba? So, that would falsely decrease the number of circulating platelets. If your peripheral blood smear is normal, you check now the morphology. Do we have fragmented RBCs? Kasi that would point towards MAHAs, no? Yung mga microangiopathic hemolytic anemias. If they are normal, then we consider other conditions such as drug-induced, infection-induced, thrombocytopenia, no? Consumptive na thrombocytopenia, idiopathic immune thrombocytopenia, and congenital thrombocytopenia. Okay? So, punta naman tayo ngayon sa leukocytosis. So, you need to identify the specific type of WBC that's predominating, causing or pushing the patient to have leukocytosis. But bear in mind that there's really no numeric cutoff to help you differentiate a primary hematolymphoid from a secondary cause. So, daanan lang natin sila briefly. Neutrophilia, so the most important cause would be infection. And it's important to differentiate a leukemoid reaction from a primary hematologic malignancy such as your leukemias, no? Pag sinabi natin leukemoid, parang leukemia lang, no? So mataas ang WBC count, but it's really usually in response to a trigger, like an overwhelming infection, for instance. So for this purposes, no, usually ginagawa dito is you get the LAP score. Okay, so that would differentiate leukemoid reaction from a chronic myelogenous leukemia. Okay, so but that's seldom done nowadays. So lymphocytosis, here it's quite important to really see the morphology of your lymphocytes. So always request for a peripheral blood smear. And there's a QR code there showing the different causes of lymphocytosis. So just go over them during your free time. Okay? So actually the problem in lymphocytosis is that it's not really very specific for a particular condition, diba? So usually you would have your viral causes, malignant causes, but it's not really very specific. Okay? So hindi rin ganun ka-revealing kumbaga, no? If you see lymphocytosis, it really doesn't point towards a specific condition. Okay? So just go over the table there in the QR code. Eosinophilia. So usually this is defined by an absolute eosinophil count of more than 500. Typically seen in a lot of conditions like parasitic infections, but also seen in allergies, not just towards environmental factors, but allergies towards drugs, towards food, and malignancies, collagen vascular diseases. Be wary lang if it's already very high, typically an AEC of more than 1,500, so that's a red flag. You want to look for more serious underlying pathology. So basophilia is something very rare. Actually, as a medical technologist, I've never seen an actual basophil from an actual patient sample. Nakikita ko lang yan sa yung mga rounds I mean yung moving type na exam, 'di ba, sa laboratory natin. Yung ikot-ikot tayo tapos may mga prepared slides there. No, pero in an actual patient sample, no, something very very rare, no. So you want to suspect for myeloproliferative conditions like PV or CML, no. Ayun. So, usually sa CML, tumataas talaga yung basophils. So, that's something of a red flag as well. Okay? If you see a lot of basophils in your patient. So, monocytosis, not also very common. So, if you see this, you should also be wary. Baka meron tayong primary na hematologic disorder. Especially among the elderly individuals, they may have myelodysplastic syndrome or yung mga chronic na myelomonocytic na types of leukemia. So, leukopenia, you have low WBC count. So here, what's important is you need to identify the specific subtype that brings about the decrease in the WBC count. So neutropenia, typically defined as an ANC of less than 1,500. So paano nga tayo uli nagko-compute, by the way, ng ANC? So simply you get the WBC count, multiply it with the percentage ng neutrophils natin, 'di ba? So for example, ang WBC count mo is 1, no? Mababa yung leukopenic siya eh. And then you have a percent neutrophils sa differential count mo na 80%, so that's 800, diba? So that's simply 1 or 1,000 times the 0.8, so 800. Ganun lang siya per microliter. So this is stratified based on severity. So mild cases of neutropenia, that's defined as an ANC of 1,000 to 1,500. For 500 to 1,000, you have moderate, and then severe, it's less than 500. Okay. So, itong neutropenia usually seen in the setting of patients who are receiving chemotherapy, diba? So, there's a need there that's typically expected after a few days after receiving the chemotherapeutic drug. So, lymphopenia, important etiologies would include HIV, steroid use, alcoholism. So, check for evidence of fungal infection, check for lymphadenopathy, splenomegaly that can point towards the underlying etiology. So, again, these are not pathologies by themselves, but they are signs that there is an underlying problem. Monocytopenia, very rare. You see it in aplastic anemia and hairy cell leukemia. Okay, so let's go to bleeding and thrombosis. So the most important predictor of bleeding risk is a prior episode or a prior history of bleeding. Okay? On the other hand naman sa thrombosis, so ano naman yung mga risk factors natin for thrombosis? So depende yan whether we're talking about an arterial or a venous thrombosis. So kapag arterial thrombosis, it's typically atherosclerosis. Kapag venous thrombosis, ayan na yung mga immobility, recent surgery, malignancy, yung may prothrombotic state talaga. Okay? So, and certain genetic predispositions that are actually not as rare as we once thought, no? Kasi in the Philippines, we don't usually test for it, diba? So, hindi lang natin alam. Pero when you test for it, na yung mga factor V latent mutation, no? So, turns out meron din palang mga ganong cases talaga. Spontaneous hemarthrosis and muscle hematomas, they are a hallmark of moderate to severe clotting factor deficiencies. So we would usually see this in those with hemophilias. Okay, if you see a patient with hemarthrosis, no, that should really alarm you, no, and probe you to work up further. Mucosal bleeding naman, you think of a platelet problem. Okay? So kapag deep yung muscle yung problem, soft tissue yung bleeding, you think of factor deficiencies. So magsasagot tayo sa exam, yung sasagutin din natin should be a factor deficiency. Okay? Whereas kapag mucosal bleeding or pag petechiae, yung sinabi sa inyo, hindi mga ecchymosis, hematomas, you think of more of platelet or vascular. Okay? Mga Ehlers-Danlos, platelet disorders. No? So let's go to leukemia. So si leukemia pwedeng acute or chronic, and typically this is differentiated based on the percentage of the blast count. So sa acute, typically you have a higher blast, you have more of that immature cells. Sa chronic naman, more of the mature cells naman tayo. Okay? So actually, even with your CBC, you can already surmise no, whether it's an acute leukemia or a chronic leukemia. And of course, sa exam, di ba? Doon natin siya gagamitin. Pag nakita mo yung CBC mo, konti lang yung mature cells, tas puro blast talaga siya, think of acute. Pag chronic, makikita mo talaga maraming laman yung CBC. So for example, sa differential count natin, you have neutrophils 10%, stabs 8%, metamyelocyte 6%, myelocyte 7%, tapos myeloblast or blast 12%. So ang dami, 'di ba? Lahat ng stages ng development ng white blood cell natin represented. You think of a CML, ganon, okay? Or a CLL. Pero kapag acute leukemia, makikita mo dyan usually, example, neutrophil, 20%, tapos makikita mo blast, 40%. Yun lang. Walang masyadong equal dun sa distribution. So that should give you a clue, no? Na baka mas acute na leukemia ito more than chronic. Okay, but of course, no, there are definitive ways to diagnose it. Just to give you an idea. So myeloid, of course, myeloid lineage, lymphoid, you have the lymphoid. Okay, so let's go to acute myeloid leukemia or AML. So this would be defined as having more than 20% blasts of the myeloid lineage, diba? So myeloid, diba? All the rest except for the lymphoid. Okay, the lymphocyte, the lymphoblast. Tanggalin mo lang yun, lahat sila myeloid. Okay, more than 20% blasts from that lineage, that's AML, except for certain conditions wherein you have a genetic mutation already identified. So in the era of cytogenetics, we have identified that certain cytogenetic abnormalities would already tell you it's acute leukemia. Okay, you don't need to have that more than 20% blast count. So example, translocation 821, inversion 16, translocation 1616, and 1517. You might recall 1517, very diba? Buzzword to, diba? So this is the translocation that you see in M3 or the acute promyelocytic leukemia or the APL-APML. Okay? So pakitandaan si translocation 1517. So AML would account for majority of the acute leukemia, so 90% among adults. The median age is 68 years old and it would generally have a poor survival. Most cases would actually have no apparent cause. Pero pag tinanong tayo what would be the most common risk factors, you have example, radiation exposure or chemotherapy. Okay, so treatment, no, you have the classic 3+7 chemotherapeutic regimen composed of anthracycline plus cytarabine. And then you follow it by a consolidation therapy. For our purposes, no, just remember the 3+7, no, so anthracycline plus cytarabine. So in AML, you will have myeloblasts that would contain a rod-like structure there in the cytoplasm, no? So ito, no, ito nandito. So this is what you call the hour rods. They are not uniformly present, but when you see it, no, it's virtually AML. Okay? AML is virtually certain if you see the presence of hour rods. Okay? Iba naman yung bunch of hour rods. No? Pag sinabi nating bunch of hour rods, that's what you call the fagot cell. No? Ang fagot cell, AML pa din naman siya, but it's more suggestive of a specific type of AML which you call the acute promyelocytic type of leukemia, no? APML. Yung sinasabi natin kanina. So this one is a highly curable subtype. It's associated with DIC because the promyelocytes would have the primary granules there, and when they are released, they are actually able to trigger DIC. Ang tatandaan natin dito is a translocation 1517 that would encode for the PML RARA. Okay. So how do we treat APML? So we give an agent that would promote differentiation. Okay, so that's the problem kasi sa acute promyelocytic leukemia. Because of the translocation, the differentiation is stopped, no, to the promyelocyte stage. So you want to further differentiate that cell. So you want to give ATRA or ATO, all transretinoic acid, which promotes differentiation. So for CML, what you want to look for is the BCR-ABL fusion gene that's brought about by the translocation 922, resulting in the Philadelphia chromosome. So ito yung hahanapin natin when you see translocation 922, think of CML. Okay? So actually sinasabi nga na pag wala yung translocation 922, no, na CML, that is a poor prognosticator. No, sabi ng iba, baka kasi hindi talaga siya CML, we haven't really discovered what it is. Okay, kaya nagiging poor prognosticator. So it's really the identity of CML, this translocation. So this would account for around 15 to 20% of adult leukemias, and just the same, ionizing radiation is a risk factor. So sa mga leukemia, no, wala talaga tayong any specific physical finding, okay, or specific complaint. But splenomegaly would be the most common physical finding in patients with CML. So a high basophil count, as I said earlier, is actually quite alarming. It would be associated with CML among other conditions. You will have pruritus, diarrhea, flushing, and GI ulcers. Sa CML, may gamot naman tayong naibibigay. So that's in the form of your TKIs, your tyrosine kinase inhibitors. And yung pinakauna dyan would be imatinib. But of course, you have second and third generation TKIs nowadays. So you have nilotinib, dasatinib, bosutinib, and ponatinib. So among all of these TKIs, what's unique is ponatinib, which is optimal for those with the so-called T315I mutation, or whenever there's already failure of more than 2 TKIs. Okay, so that's a third generation TKI, ponatinib. Okay. So next, let's go to acute lymphoblastic leukemia. So this time, sa mas bata naman natin nakikita to, no? So it's actually the most common leukemia in children, but only accounts for around 20% in leukemias among adults. Okay, so kapag ay mga lymphoblastic na leukemia, no, so some of them, they would have a lymphoma na counterpart, and that happens when the presentation is predominantly sa soft tissues, no, rather than hematologic sa dugo. Okay, universally fatal if left untreated, and in these cases, yung ALL examination of the CSF through lumbar puncture is essential. Okay, so mas mahirap tong gamutin, no, yung mga acute lymphoblastic leukemia. So, for CLL naman, this one is an indolent type of malignancy in contrast to the other ones. No? So, a lot of them actually would be undiagnosed. They go unnoticed for many years. Some of them would be diagnosed as an incidental finding lang sa CBC, mataas yung lymphocytes, tapos na work up, CLL pala. Okay, so it's a malignancy of the mature B cells. And just the same, it would have a lymphoma counterpart, no? When the presentation is primarily tissue-based rather than bone marrow-based. So that's what we call small lymphocytic lymphoma. So medyo nomenclature lang yung difference. So it's actually very common in the elderly, probably the most common leukemia in the elderly, and it would have a variable course. The problem is it can be complicated by immunodeficiency. Kasi nga, it's a problem of the B cells. So, treatment is risk stratified. A lot of these cases are, parang OB, no, expectant management. Diba sa OB, pag di mo na alam yung sagot, expectant management. No, so, watchful waiting may be done. Okay, we also have more, newer modalities that we can use. No, targeted therapies, yung mga ibrutinib, BTK inhibitors, the PI3K delta inhibitors. Okay, so yung mga yon. So you have here the peripheral blood smear of a patient with CLL, and you can see the so-called smudge cell, the one in the middle, this one. So yan, no? So this would actually represent a distorted cell. So, diba, when you prepare a peripheral blood smear, you get 2 slides and then you smeared it. So during the process of smearing, some cells tend to be fragile. It's typical of CLL. So yun yung tinatawag nating smudge cell. But take note that this is not specific. Okay, it's only suggestive, but it's not specific for CLL. Now let's go to the plasma cell disorders. So plasma cell disorders are monoclonal neoplasms with common progenitors in the late B cell lineage, includes multiple myeloma, Waldenstrom's macroglobulinemia, amyloidosis, and heavy chain disease. Okay, so pinaka-common dito will be, pinakasikat, no, would be multiple myeloma with a median age of 69 years old. But when you go out to practice, baka lang magtaka kayo, no, at least from what I see, no, from my experience during residency, a lot of these patients among the Filipino population, they tend to be young, no? They really tend to be quite way younger than the median age that's, written in the references. So baka kayo, you would want to do a study, epidemiology ng in the Philippines. So you have the NRAS, KRAS, BRAF mutation. So this one is the most common mutation occurring in more than 40%, highest among African Americans and the Pacific Islanders. So bone pain would be the most common symptom in multiple myeloma. And in multiple myeloma, there is a diagnostic parameter here in the next slide. And there are actually multifactorial causes for the renal failure, but the most common cause would be hypercalcemia. Okay? So what's unique also about MM is that you have a serum marker for survival to predict survival, and that's in the form of your beta-2 microglobulin. So in terms of diagnostic criteria, you need to establish the clonal bone marrow plasma cells or extramedullary plasmacytoma, and you need one myeloma defining event. No? Kaya nga siya tinawag na CRAB, naalala yung acronym na CRAB. So hypercalcemia, renal insufficiency, anemia, and bone lesions or bone pain, diba? So yun. So there are specific cutoff values for this. Okay, so you might want to familiarize yourselves with these values as well. In terms of treatment, ang myeloma, medyo makulit, no? Usually, pabalik-balik yan. But we have the regimen na lenalidomide, bortezomib, dexamethasone, which achieves close to 100% response rate. Just take note that if your patient is using bortezomib, you might be referred the patient with MM, hihingi sila ng IM guidance, no? How to manage the patient supportively. So remember to give herpes zoster prophylaxis for the bortezomib and DVT prophylaxis if you're using lenalidomide or thalidomide. Okay? Of course, in the Philippines, wala tayo atang thalidomide because of the, yung pocomelia na side effect. For Waldenström macroglobulinemia, you have MYD88 mutation, MYD88. Okay, so majority of patients would have this mutation, and the most common clinical manifestation would be hyperviscosity, symptoms of hyperviscosity. Okay, so you can have lymphadenopathy and hepatosplenomegaly, but unlike multiple myeloma, wala yung mga bone pain, hypercalcemia. Okay, so you have treatment options like plasmapheresis and ibrutinib, yung BTK na inhibitors natin. So let's briefly talk about some hematologic abnormalities that we see in COVID-19. Of course, this is still a growing body of knowledge, but typically this is a hypercoagulable state. So that's the predominant picture. In fact, when we started having COVID-19 patients, that's really when I started seeing patients with documented episodes of pulmonary embolism, DVT, na left and right talaga, no? Dati nag-order kami ng CTPA, wala naman talaga ako nakikitang pulmonary embolism until COVID-19 came. Anyhow, you have the so-called CAC or COVID-19 associated coagulopathy. Okay, so it's distinct from DIC because in COVID-19, as we mentioned, it's more of a hypercoagulable state. Okay, whereas in DIC, of course, you know that the predominant finding would be bleeding rather than thrombosis. Okay, so patients with hemoglobin disorders are at increased risk for severe COVID-19. So example, yung mga may sickle cell disease, thalassemias. Okay, so anyhow, you might want to do prophylaxis because they are at risk to develop thromboembolic complications and even arterial thrombosis. So for the onco part of the board examination naman, our focus wouldn't really be on the specific cancers, individual cancers in treatment. Hindi naman ina-expect ng board of examiners na alam nyo yung specific chemo drug to give unless it's very typical. So I would suggest that you go through the specific cancers and notable chemotherapeutic regimens, but usually our emphasis would be in terms of the prevention, the screening, the risk factors, and so on. Yung mga supportive aspect of onco. Anyway, let's go to the meat of matter. So, in terms of the etiopathogenesis, it would involve unrestrained cellular proliferation, and mostly they would arise spontaneously. But of course, we have familial causes of cancer. So the diagnosis should not be made without obtaining tissue. So optimally, it would be an excision. You remove the entire thing. But if you're not able to do that, then we can just do an incision biopsy. So clinical staging would be based on PE and imaging, whereas pathologic staging, it would be post-op already because it would take account information obtained during surgery. You're very familiar with the TNM staging, which is the most widely used staging system. T stands for the tumor based on the size of the tumor, N for the nodal involvement, and M for any presence of metastasis. So here, it's very important to assess the patient's physiologic reserve and presence of other comorbid conditions. And the most common ones that we use in practice would be the ECOG and the Karnofsky performance status. The Karnofsky performance status is a little bit more difficult to memorize, but I suggest that for ECOG, you really remember this. Okay? Kasi kung hindi man sa onco lumabas, pwede kayo tanongin ito sa PrevMed. Okay. So for ECOG, you have grade 0 to grade 5. Pagdating sa 5, dead na yung patient. Sa 0, ito kayo, fully active, able to carry out all pre-disease performance without restriction. So kayo yun, yung kayang-kaya mag-aral mula umaga hanggang umaga ng kinabukasan. Okay, pagdating sa grade 1, restricted with in terms of strenuous activity. Ang tinatandaan ko dito personally ay pag nag-aaral ako ng mga tables, I look for an anchor. Meaning to say, yung more than ganito, less than ganito, yun yung magdi-differentiate ng 2 grades, 'di ba? Para hindi mo siya makakalimutan. So, I just remember that grade 2, you are up and about in more than 50% of waking hours. Grade 3, kapag hindi ka na up and about in more than 50%, no, you're already confined to a bed or chair more than 50% of the waking hours, 'di ba? So, automatic alam mo na yung grade 2 and grade 3. So, madali nang maisip, yung grade 1, edi yung mas active pa doon sa grade 2. Grade 4, edi yung mas disabled pa. Okay, so for grade 4, you're completely disabled, you cannot carry on any self-care. So in terms of response naman to treatment, no, when we say complete response, so of course, disappearance of all evidence of disease, partial response, more than 50% reduction in the sum of the products of the perpendicular diameters of all measurable lesions. Okay, so progressive disease increased by more than 25% of what I mentioned earlier, the products of the perpendicular diameters of all measurable lesions, whereas stable disease if it doesn't meet any of the criteria earlier. Okay, so let's briefly talk about the tumor markers. So alam nyo na rin to, review lang natin together. HCG, you have your gestational trophoblastic diseases, yung H-mole or high datidiform mole. Dito marami nagkakamali, nako-confuse, no? Thyroid cancer. Pag narinig kasi natin thyroid cancer, automatic, thyroglobulin. But remember, for medullary thyroid carcinoma in particular, the tumor marker that's appropriate there will be calcitonin. Alright? Catecholamines for pheochromocytoma. AFP, of course, for HCC. CEA, not very specific for a lot of conditions. No, we use it for colon cancer. Prostatic acid phosphatase for prostate cancer. NSE for small cell tumors. LDH for lymphomas. Diba part din yung LDH actually nung prognostic scores natin. Remember? Okay, so for PSA, prostate cancer again, and then the various CAs. So bear in mind, CD30, you see it in Hodgkin's disease. In particular, diba, CD15 and CD30, these are the cluster of differentiations that are particular to Hodgkin lymphoma. Because that's what you see in the Reed-Sternberg cell. Diba? Naalala, yung may owl's eye na itsura, that's your RS cell, that's virtually diagnostic of a Hodgkin's disease. So in terms of prevention and early detection, these are the interventions that were specifically highlighted in Harrison's that would have studies backing them up, no? So the most important would, of course, be smoking cessation. So this would prevent lung cancer, a lot of cancers in the aerodigestive tract, and even those organs that are not directly associated with exposure, no direct exposure to smoke, like the kidneys, the bladder, pancreas, right? So, increasing your physical activity may also prevent colon and breast cancer, increase dietary fiber, weight loss, and sun avoidance for a lot of skin cancers. So, in terms of screening, no, baka malito kayo kasi may mga differences with the screening recommendations probably in PrevMed, no, or if you're reading other references. Because there are different bodies that offer screening recommendations. In IM, yung sinusunod natin dalawa, the USPSTF, Preventive Services Task Force, and the American Cancer Society. So the table here, no, is mainly from the US Preventive Services Task Force, and usually naman the same, no, meron lamang minor differences. So I would suggest that if you study them, just be familiar with what body, no, nanggaling yung recommendation. So again, this is USPSTF. So mammography is every 2 years, starting at the age of 50 until the age of 74. Take note that there are no recommendations for self-examination and clinical examination. I mean, actually, they're not recommended. Okay? So, baka may trick question tayo doon, no? So, tanungin, how often should you do self-examination? How often should you do clinical examination? Kasi, di ba, in surgery, parang may sinasabi na you should do daily self-examination. But, the USPSTF actually does not recommend doing self-examination. Okay? Because sinasabi nga natin na low sensitivity naman, tapos baka it would also make you think na you are checking yourself for cancer, tapos na-forgo na yung paggagawa ng mammography. Okay? Pap smear every 3 years at the age of 21 until 65 years old. If you combine it with cytology, you can do it every 5 years. Sa colonoscopy, this is very important, mga screening techniques for colon cancer. So this is typically done every 10 years starting at the age of 50. Take note that in the US Preventive Services Task Force, the recommendation is still 50, but it can be considered as early as 45. Okay? Meron kasi kayong mga babasa siguro na recommendation to start at 45, but the recommendation is 50, but at 45, you can already start screening. This is in contrast to yung sinasabi sa ACS, American Cancer Society, na sinasabi na you should start screening na at 45. Okay? So, yun yung difference natin doon. So, check nyo na lang sa question kung ano yung specifically, anong source yung gusto nilang isagot natin. So, for sigmoidoscopy, this can be done every 5 years. FOBT every year. Fecal DNA testing every 1 to 3 years. FIT every 1 year, and CT colonography every 5 years. Okay? So, take note yung FIT, no? So, I'll also take this opportunity to discuss this a little bit. Yung FIT natin, actually, this is not validated for use to check for, tawag dito, blood and stool other than for cancer screening. Okay? So, do not use this test if you want to check for upper GI bleeding, lower GI bleeding. Huwag natin gagamitin yon. Okay? Especially among critically ill patients, no, that because very minor bleeding that's not necessarily significant, or even the trauma from the NGT could already induce sufficient bleeding that could render the FIT and the FOBT to turn positive. Okay? So again, ano lang yung purpose nila for cancer screening? Don't use them to check if there is an upper GI bleeding. Okay? So low dose chest CT, you use this for those 55 to 80 years old. Very, very specific ang recommendation na to. In those with more than 30 pack-year smoking history, still smoking, or those who have already quit within the last 15 years. So maraming numbers dito sa low-dose chest CT, bear in mind. Okay, PSA for 55 to 69, but the decision to screen should be an individual one. Okay? So it's not specifically telling us na everybody 55 to 69 outright kailangan PSA talaga. Okay? DRE, no individual recommendation in terms of doing DRE for prostate cancer. So here is just a table showing you the different carcinogens and the associated cancers. So for alkylating agents, you can have AML and bladder cancer. Another thing worth mentioning about alkylating agents is that they are notorious to cause infertility. So tatandaan yun. Androgens for prostate cancer, arsenic for lung cancer, asbestos also lung cancer and the pleura. I know, take note na, I know that you would often think of mesothelioma when you hear the word asbestos. Tama? Pero when you're asked, what is the most common? The answer is still lung cancer. Okay? Most common cancer associated with asbestos exposure is still lung cancer. It's just that mesothelioma, di ba, parang matunog, no? Quite unique because this is also associated with asbestos exposure. Okay? Moving on, you have benzene for AML, chromium for lung cancer, DES or diethylstilbestrol for clear cell carcinoma. But I need to emphasize that this is clear cell carcinoma of the vagina. Okay? Kasi pwede tayo lituhin, sabihin cervical cancer, clear cell carcinoma of the cervix, no? This is specifically referring to cervical cancer. I mean, clear cell carcinoma of the vagina. Okay? Epstein-Barr, Burkitt lymphoma, nasal T-cell lymphoma, depending on the race as well. Estrogens for breast cancers, endometrial cancers. Alcohol, of course, alam nyo na yan. And H. pylori, malt lymphoma of the stomach, on the GI tract. Diba? That's why in cases of mild cases lang, early stages of malt lymphoma of the gastric tissues, usually mere eradication of the H. pylori can get rid of the cancer. Okay? Okay, you have Hep B, Hep C, of course, liver cancers, HIV, like non-Hodgkin lymphoma, even Hodgkin lymphoma, Kaposi sarcoma. But the relationship with Kaposi sarcoma kasi is tied with the risk factor also to develop the herpes virus 8, diba? The Kaposi sarcoma associated virus. Okay, HPV, alam na natin, HTLV, adult T-cell leukemia or lymphoma. Okay, what else is unique here? Phenacetin, no? It's cancer of the renal pelvis and bladder. Do remember that, phenacetin. So, yeah, naulit dito yung phenacetin for emphasis. Okay, vinyl chloride, also quite unique. Angiosarcoma of the liver. Tandaan na rin yun, no? So, schistosomiasis, in particular, this would be for schistosoma hematobium, so bladder cancer. Specifically, squamous cell carcinoma. Okay, ulit, squamous, ha? Marami nagkakamali dito. Pwede tayong lituhin, no? Lagyan tayo ng transitional cell carcinoma of the bladder, di ba? But the correct answer should be squamous cell carcinoma of the bladder. So, let's go to the common paraneoplastic syndromes. So, you have hypercalcemia of malignancy. So this would be mediated by your PTHRP, usually for squamous cell carcinomas. No? And majority of the cancers na may hypercalcemia would be mediated by PTHRP. But some of them would be mediated by 125 dihydroxyvitamin D. So this is in the case of your lymphomas. Okay? So pag mga lymphomas yan, no, usually we can use or we can do trial steroids para kasi usually magre-respond sila if it's mediated by the 125 dihydroxyvitamin D. And even granulomatous diseases, no, although not cancers, some of them would also respond with a trial steroid treatment. Sayad, of course, yung vasopressin natin, the ADH or vasopressin. Cushing syndrome for ACTH, very typical of small cell lung cancers. Erythrocytosis, yung nabanggit natin kanina sa hema portion. Diba? Mediated by your erythropoietin, seen in cases of renal cell carcinoma, hepatoma, cerebellar hemangioblastoma, and if you recall, sa algorithm sa pinakababa, meron pang uterine leiomyoma. Okay? Thrombocytosis, this is mediated by your IL-6, no, which also mediates the elevation of your acute phase reactants. So, seen in lung cancers, GI cancers, breast, ovarian, and lymphoma. Eosinophilia, so this is mediated by IL-5, seen in LLL, leukemia, lymphoma, and lung cancer. You have your anti-NMDA receptor encephalitis, typically seen among teratomas, no? Especially in young women. So, yun yung mga buzzwords na hanapin natin. You have a young female suddenly presents with changes in behavior, later developing changes in sensorium, tapos on workup, merong pelvic mass, no? Turns out to be a teratoma. You think of anti-NMDA, alright? So, tinatanong yan. So, cancer treatment, no, we need to take note of therapeutic index, which basically is the separation between toxic and therapeutic doses of the drug, and some late consequences. Okay, for long-term effects, no, so example for steroids in the bone, you can have osteoporosis, vascular necrosis, no, not just for cancer patients, some rheuma patients who are on long-term steroids, that's also something that you need to watch out for, biglang nagkakaroon ng vascular necrosis of the femoral head, no. For methotrexate, you can have neuropsychiatric changes. Vincristine as well, neuropathy din siya. Steroids in the eyes can cause cataracts. For the heart, very notorious itong dalawang to, pakitandaan. Your anthracyclines such as doxorubicin, daunorubicin, they can cause cardiomyopathy. Okay, and typically, it's a dilated type of cardiomyopathy. And trastuzumab as well, no? But what's good about trastuzumab is that it's really reversible. No? After you stop the drug, usually nagre-reverse naman yung cardiomyopathy. Okay, so this is the reason also why some cancer patients, they need an echo prior to giving the chemotherapy. Bleomycin, notorious for pulmonary fibrosis. You have a 50-year-old whatever man suddenly develops exertional dyspnea, no, with crackles, bilateral on auscultation, with interstitial fibrosis on CT scan. So you think of pulmonary fibrosis. Okay, your cisplatin, your platinum agents can cause decrease in kidney function. They can cause wasting of magnesium. That's why patients on cisplatin, no, pag naka-experience kayo working in the cancer institution or cancer wards, you would notice parang gripo yung mag-sulfate natin dun. Bigay tayo ng bigay, iniihi lang din ng patients, no? So hypomagnesemia. Alkylating agents, as I mentioned, causes infertility. Okay. So there. So for oncologic emergencies, they are typically divided based on the underlying mechanism. So if it's related to the pressure or obstruction, such as SVC, cardiac tamponade, if it's because of a metabolic problem, a paraneoplastic condition, or a treatment-related complication. So SVC, this is because of the superior vena cava obstruction. Most common etiology would be lung cancer, pero in the younger population, we have lymphoma. Okay, metastatic tumors, and even benign causes. So, itong mga benign causes, no, this is brought about by, mga advances in technology because now we have intravascular devices that we can insert. No, that can also cause obstruction of SVC. Now, in terms of clinical feature, madali lang maalala because you know, of course, that the pathophysiology involves impaired venous return, right? From the head, the neck, the upper extremities. So, of course, yung clinical findings would also reflect pooling, diba, in that area. So, neck swelling, facial swelling, hoarseness, tongue swelling. So, mapula yung mukha, no? Plethoric sila. So, those are the things that you need to look for. So, PE findings, you have dilated neck veins, collaterals along the anterior chest. Tracheal obstruction would be a potentially life-threatening complication which demands, of course, emergent therapy. So, SVC, even if an imaging would help, no, kung talagang barado yung superior vena cava natin, at the end of the day, the diagnosis is still clinical. Okay, we diagnose SVC clinically. We don't need to wait for imaging findings. Diba? So on X-ray, the most significant finding would be a widening of the mediastinum, typically on the right side. But the chest CT scan would provide the most reliable view of the mediastinal anatomy. Okay, you may have diminished or absent opacification of the central venous structures. And tissue biopsy would establish the etiology. Okay. So, ano ba yung pwede nating gawin? You can offer symptomatic relief. You can give diuretics, low-salt diet para mag-decrease yung venous, tawag dito, yung fluid retention, head elevation para hindi impaired yung venous return, oxygen therapy as well. For palliative, you can offer intravascular shunts. So, ano ba yung mga mas directed na treatment of SVC? Now, that would depend on the specific etiology. And that is the reason why earlier minention natin that tissue biopsy would establish the etiology, right? Kasi depende siya kung ano yung nagkakos ng SVC syndrome. So, for example, lymphoma, you can give steroids. RT, kapag non-small cell lung carcinoma. Pag small cell, chemo naman tayo. Okay? So, do remember that. Lalo yung difference between small cell and non-small cell. One is RT, one is chemo. Okay? So, we're not really a fan of giving steroids left and right. Back in the day when I was an intern, I do remember my residents giving steroids for everyone with SVC. Okay? Kasi parang for what it's worth. But in reality, we know that it's only if you're really suspecting lymphoma. Otherwise, it's not going to work. Spinal cord compression. So, the majority of cases are caused by lung cancers, and the most common affected site would be the thoracic spine. And the most common initial symptom would be a localized back pain, tenderness, exacerbated by movement, or coughing and sneezing. So in terms of diagnosis, just a simple neuro-PE, a good neuro-PE can already tell you na baka may spinal cord compression, di ba? Pain on straight leg raise, ganun. So a plain film would be suggestive, but syempre hindi naman siya talaga yung best, di ba? The best would still be an MRI. Kasi kung soft tissue yung gusto mong tignan, nag-i-impinge pa siya sa nerves, MRI pa din tayo. Although yun nga, ang bad side nito ay matagal kasi siya, no? So in SCC, you might be able to appreciate the so-called Dermot sign, which is a tingling or electric sensation down the back and the upper and the lower limbs upon flexing or extending the neck. So this can be an early sign of spinal cord compression. Then you also have the cauda equina syndrome, which should have a saddle distribution, diba, of the diminished sensation. Okay, in terms of treatment, so generally the initial treatment of choice would be radiation plus glucocorticoids. So we really want to catch them early. Kadalasan kasi if you catch it at months later on, chronic na yung spinal cord compression, atrophied na yung nerves natin, usually the steroids wouldn't help already. Okay, chemotherapy may have a role for those chemosensitive tumors. So more often successful in patients who are still ambulatory and have good sphincter control. Yun nga, sabi natin, no, if you catch it early on. Okay, that's why you need to have a high index of suspicion. Nagmamadali tayo. Okay, so neutropenic enterocolitis, this involves typically inflammation and necrosis of the cecum, but it could also involve other segments of the colon. It can present with right lower quadrant representing the location of the cecum. Para siyang appendicitis, no? Can have rebound tenderness, tense distended abdomen in the setting of a patient with neutropenia. So, kadalasan sa atin, no, nakikita natin to kapag nakikimo yung patient, bumabagsak yung neutrophils, nagne-nadir sila, tapos nagde-develop na ng diarrhea, sometimes bloody also. Yun. So, you can request for a CT scan and you want to see yung bowel wall thickening, okay, particularly in the cecum. Okay, and signs of inflammation like mesenteric fat stranding, there can be some ascites as well. Treatment, actually, antibiotics, but other than supportive, no, you want the neutrophils to increase, right? So you can give myeloid growth factors which have been shown to improve outcomes. Bowel rest and nasogastric suction, so parang PGO, no? You're like managing it as if PGO siya. Surgery, kung meron ng complications such as perforation, peritonitis, and so on. Lastly, pag-usapan natin yung tumor lysis syndrome. Si tumor lysis syndrome, this would be secondary to the destruction of large numbers of rapidly proliferating neoplastic cells. So, meaning to say, what is the typical setting kaya na nagti-TLS sila? Kung nagkakaroon ng destruction of large cells, it would follow that it would occur during or after chemotherapy. Lalong-lalo na kung first episode ng chemotherapy because it would be related to the tumor burden, right? So, in terms of laboratory values or findings, no, it would reflect also cell lysis. Yung mga intracellular na analytes, yun yung tataas. Example, Of course, yung nucleic acids, di ba, ma-degrade sila, so you will have hyperuricemia. Potassium is intracellular, mag-hyper-K, mag-hyperphosphatemia, and the reverse is true for calcium, babagsak naman siya. Okay? So, kung may mga highly proliferative neoplasms, no, you can have spontaneous TLS. Example ng highly proliferative neoplasm would be Burkitt's lymphoma. So, TLS in that setting can happen even without giving treatment. No? So, management would be giving allopurinol, hydration. Hindi na tayo nag-alkalinize. No, we don't give sodium bicarbonate anymore. So for the last slide, this is a very useful algorithm found in your Harrison's. So management of tumor lysis. So a very important pillar here is actually prevention. No? And how do we prevent tumor lysis? Especially for high-risk individuals, you need to hydrate. No? 3 liters of normal or half saline per meter square per day. You also want to give your xanthine oxidase inhibitors in the form of your allopurinol and monitoring of serum chemistry. Okay? Kung ano naman, no, normal naman, uric acid is less than 8, serum creatinine is less than 1.6, so kindly correct this, should be less than 1.6, then we can start chemo and just do close monitoring. Okay? We need to do close monitoring because, tumor lysis can just happen out of nowhere. Minsan normal, tas the next thing you know, hyperkalemic, tas arrhythmic, tas patay na. Ganun siya kabilis. No? Very easy to remember, potassium of more than 6, the rest are more than 10. Then you can start hemodialysis kung nangyari to, na nag more than 6 siya, tapos yung iba nag more than 10 na siya. HD agad to, no? Kung hindi, mahirap siyang habulin. What if from the outset, mataas na talaga siya? Then we need to correct, no? We need to look for some reversible causes like obstruction, especially in the setting of malignancy. Baka naman bukol pala na nagkakos ng obstruction. You can give your recombinant urate oxidase per IV. So this is your rasburicase case. Pag walang improvement, then delay muna yung chemotherapy or HT tayo. Okay? So that's it, no? Rather straightforward naman yung tumor lysis. Mahirap nga lang in real life kasi hahabulin mo talaga siya. So this is already the last slide. This is by no means an all-encompassing lecture for Hema-Onco part of IM, but I wish you all the best. I hope that we were able to give you a head start at least and some pointers on how you can go about your studying for the Hema and Onco part of IM. So good luck and God bless. Thank you.